Hello and welcome back to day 31 of 90 Day Dental. So we're halfway through oral surgery and today we'll be covering ridge preservation techniques with Sami Stagnall. Take it away.
Right, ladies and gentlemen, thank you for joining me here on day 3 of the 90 Day Dental Oral Surgery segment. And we're moving on from the last few days. If you've stuck with me thus far, thank you very much. Today we're discussing ridge preservation after yesterday's discussion on extraction techniques. And essentially this point now takes us to what we do with managing the extraction socket once that tooth is out. And for those of you who might not have been involved in implantology before, ridge preservation is quite a topical subject. It's something that comes up quite a lot and something that gets discussed to a great degree, but actually it finds its uses beyond simply preparing ridge sites for implants. And it's often used interchangeably with the phrase ridge augmentation as well. So you might hear that, or socket preservation. We're not preserving the socket, we're trying to preserve the ridge. Ultimately, what we're trying to do with this procedure is maintain the shape of the alveolus once that tooth is out. One of the reasons for doing this is because you want to think with the end in mind, as we discussed in the very first of these episodes. And hopefully I'm going to cover what is actually quite a complex and in-depth subject, and I could go on for hours about this really because of all the evidence that exists around it. But we're going to try and cover some real basics about the concept here today with you. So when we take teeth out, we know that there are physiological changes that happen in that extraction socket. And first and foremost, I need to cite the fact that PerioSpot, Dr. Barbosa, who produces these fantastic animations, has pulled this together really easily, and it makes it super simple to understand. If you want to follow this subject up afterwards, their write-ups are fantastic. But you can see in the animation here that those processes that we learned about in dental school still the same biological processes that happen to every single extraction socket, and that has a massive influence on things like timing of implant placement and management of the use of the extraction socket. So whether you're doing dentures over teeth that have been taken out or implants, this all has a significant impact on how we manage our patients and how we explain to them. And it's all based on animal models that were done, particularly dog models here. And you can see how the infill of the socket moves from the blood clot through to woven bone and then into mineralized bone by day 30. And that continues to mature for 4 to 6 months. Now, when you take a tooth out, you will inherently have bony volume changes, and work by Jung in 2004 and 13 has shown the significance of those bony changes. It can be upwards of 50% in terms of overall volume change in that socket over that first 6 to 12 months. That's significant, and if you look at the clinical picture on the top there, you see the difference between a side that has tried where you've maintained the volume on the right hand side versus where you have lost the volume. And there's that buccal dip that you get, and that buccal dip is significant. I will come on to explain in just a second, for primarily aesthetic reasons if you're not doing implants as well as implants, but also from the point of view of bony volumes when you want to come to place dental implants. If we're taking out teeth badly, like we discussed in yesterday's segment, you can have a profound impact on the amount of bone volume left. And if you don't manage teeth properly, you may end up with significant defects, let alone effects that you can manage and graft. So again, this goes back to extraction techniques and being careful with how you're taking teeth out. But cone beam provides an extremely useful adjunct in terms of assessing the volumes that are left when you are managing teeth. Now, one of the real paramount studies that have been produced in the last few years is this one by Vivian Chapuis and the group at Bern. And what they did was look at cone beams of extractions in the aesthetic zone at time of extraction and then at 8 weeks later, and it's one of the few studies where they've been able to use cone beam so well. And they managed to divide into 2 groups looking at thin biotypes, so less than 1 millimeter buccal bone thickness, and those over 1 millimeter thick, which is thick biotype. And those in the thick biotype showed minimal changes, less than a millimeter at the crest. And you can see that in that heat zone map on the far right, where that red change shows minimal changes. And those are ideal patients where you know you're going to get minimal impact of bony change after extraction. But when you come to do it in those finer bone types, those thinner bone types, you get significant changes up to 7.5 millimeters. So we want to intercept those changes, and this is where cone beam is a really useful tool for when you are doing things like implants, to assess in the sagittal position of any tooth, how thick is that bone plate, how thin is what we call the bundle bone. That has a profound effect on how much bone is going to disappear. And if we can intercept that and minimize that, we can have definite benefits to how we're going to place our implants. Because if that bone disappears, as you can see in these diagrams from the ITI, the less bone we have and the longer we wait to come back when that bone is resorbed, the difference in bony volume around the implant, and that makes it easier to graft, is going to be significantly different. And that will have an impact on bone grafting at the time of implant placement, as well as the bony contours around the implant long term. So when is ridge resorption really going to be a problem? Because we take teeth out all the time and don't think twice about grafting the socket. Well, as you can see from these images, where the ridge hasn't been managed properly, or say where the patient presents with a delayed, when the patient presents delayed, as in when there may have been several years since they had the tooth out, there is significant changes in the buccal bone volume. That means it's typically unsightly, and where that hard tissue disappears, the soft tissue follows. Those dark shadows that are created as a result tend to mean unsightly aesthetic changes, and this is what patients notice. Patients don't necessarily notice the lack of gum tissue, but they notice the darkness that is created by the concavity there. So that ridge resorption is something that we really want to manage, and occasionally patients aren't sure on whether they want implants or not. So if we can manage that bone and keep some there and keep that volume present for as long as possible, it gives patients a chance to think about what they may want to do in the future. That is going to be significantly better than simply having left extraction sockets to heal on their own, where there's going to be significant need for grafting later, and that will be present during your CBCT examination of a tooth, and you can help inform patients based on those examinations. Now, those examinations are going to be subject to bone types. We've talked about bundle bone and the bone thickness there. Now, that diagram there in the middle is by Elian 2007, and that's a great way of defining when is or isn't the right time to consider doing ridge preservation, because it's not going to work for every single tooth. And I've talked a lot now about anterior teeth, because that's typically where we think about these things, but it does work in the posterior maxilla as well. And where we've done studies and seen evidence coming through now more recently around ridge preservation in molars, we've seen a reduced need up to 42% in this study, where patients had molar sites ridge preserved. It reduced the need for subsequent sinus lifts or sinus procedures to make room for those implants. Now, in restorative dentistry, if patients aren't suitable for implants for whatever reason, and I use this clinical presentation again, this was provided to me by Geistlich. It was a split mouth study where they did ridge preservation on one side and no ridge preservation on the other. You can see the difference, and that's absolutely clear. And we see it in our patients all the time who present with ridge work with gaps underneath, where bridges may have been fitted too soon, not allowing for proper healing, or several years later where gaps have suddenly emerged underneath. And in these patients where implants may not be suitable for whatever reason, it might be worth considering the benefits of doing ridge preservation to manage the volume more effectively. Now, that volume won't stay there forever. It's not an absolute guarantee, but some of the xenograft materials have a significant longevity, and they will last and maintain volume for quite some time. So it's worth thinking about to preserve the aesthetics under bridge site, pontic sites. But when we come to our decision making, if we are considering implants, this flowchart by Young 2018 helps you in your decision making, and it's a great tree to consider when you want to understand what might be a good course for a patient, and whether or not there are soft tissue defects or bony defects around the tooth. That's very, very important. So if that implant's not going in within 2 months, which is what the Boozer group at Bern are doing routinely, because they know that there's good evidence around it and there's good predictability, and you might be delaying that implant for a significant amount of time, so long as you have enough bone and you can preserve that bony volume with graft materials. And there's an indication there about re-entry as well, which I'll come on to shortly. But if you're going to be leaving for longer than 8 weeks, then consider ridge preservation as an adjunct to your implant treatment. And what you will be doing is saving patients further grafting down the line. It's not an absolute that they won't need grafting, but it definitely will reduce the volume of graft that they may need. Now, when we talk about bone types and bone availability, so those bottom 2 parts in there, we look at the work by Elian 2007, looking at how much bone might be present and bone types. And this was a study based on position of tooth against palatal and buccal walls. Now, Elian type 1 and 2 are those root types that are suitable to things like immediate implant placement, but equally more likely to be beneficial for ridge preservation. Type 3 is going to be much harder to engage, much harder to manage, and where you lose more than 50% of that buccal bone volume, you're going to struggle to get any buccal contouring in with xenograft or any other type of material. Now, this animation shows the process once you've decided that you are going to go down the route. And if you do decide to do grafting, as long as there's at least 50% buccal bone volume there, you can use a membrane to substitute the fact that there is a dehiscence, say, in the buccal plate where there is a thinness. Again, studies show mixed outcomes depending on whether that collagen membrane is placed on the inside or the outside, and different people argue depending on where the blood supply is coming from and the suitability of that position. But the idea that it's a barrier membrane to prevent soft tissue ingress. Now, that collagen sponge is slowly mineralized and turned into new bone. Not all of it will turn into bone. In this case, the Geistlich Bio-Oss is a collagen sponge with xenograft particles. And that bone formation is gradual. And the question that is then asked is, what point do you go back in? So when we look at studies showing how much bone is present after different uses of different materials, we can see that actually there's a significant amount of graft material still present in the sockets even after 3 months. And even still after 7 months, there is still a significant amount, up to a third of the material is still present. Allografts are different because allografts are from other human donors, so they're more recognizable by the body. They look more like natural human bone, so the body may respond to them better. But again, in Europe, we don't tend to use as much allograft as they do in the States, for example. Furthermore, studies looking at different materials have shown very little in the way of difference in outcome. And a lot of the time in things like the systematic reviews and the meta-analysis, the studies have shown that it's not simply just the material you use, it's the patient presentation, the patient type, the bone type, the thickness of the buccal wall, the soft tissue closure. These all have direct influences on it. So it's not as simple as just saying, pick the right material, there's one golden outcome. You may need to consider other factors involved in this as well. In terms of going back in, we know that most of that material is starting to have disappeared by about 4 months. So 4 months is a suitable time to consider re-intervening if you want to go back in with implants. But in most situations, people would wait up to 6 months to go back in after having grafted a site that had healed completely. And it's worth considering that the further 2 months of implant healing is part of graft maturation. Waiting much longer and beyond that, you might find that there's actually resorption and there isn't any benefit to waiting much longer. So again, it's buying patients time and maintaining volume, but it's not necessarily improving outcomes that much longer if you are waiting too long. So hopefully we've covered a few things. Key thing here is we're trying to avoid excessive alveolar resorption. Things like bundled bone are embryological in origin. When an anterior tooth is taken out, that bone will remodel. There's no way it's going to stay there. If it's very thin, it's going to disappear. If there's less than 50% of it, it will almost certainly need grafting later or flapped grafting at the time of extraction, because ridge preservation isn't going to work. Ridge preservation works really well in reducing vertical and horizontal changes, but you need to pick patients properly, and you need to talk to patients about what their options are and how it's going to improve things. Hopefully that's been a useful run through of ridge preservation today. Tomorrow, join me. We're going to be discussing wisdom teeth, indications for removal, possible complications and risks as well. And I look forward to seeing you then.
Really informative sessions, and I love how thorough he is when he goes through it all. It may be a reminder for some of us, but actually these are very, very useful sessions. Just as a reminder for everyone anyway, please like and follow us on both YouTube or Instagram, or both. And we look forward to welcoming you back tomorrow for part 4.